Hello, everybody. Welcome to our third installment of Peer-to-Peer Academy. So Peer-to-Peer Academy, what we're trying to do is just foster a community of ODs, MDs, everybody in the field to talk pretty much all things refractive cataract surgery and anterior segment surgery. We want to talk about how do we use this technology in the real world, away from the podium, everything that we hear that's, per the FDA label. We want to talk about how do we actually do these things and how do we optimize it for the management of refractive errors for our patients to get the best possible outcomes. And so that's what we're here. Today, I'm very, very happy to welcome on a couple of my buddies, Josh Davidson, Ken King, and then Neil Vadia from Chicago. So we are here together. And of course, this couldn't happen without the help from our sponsors. So big thanks to RxSight, Star Surgical, and Lenzar. So again, Neil, Josh, Ken, thanks for joining us. Priya Mathews was supposed to be here, but unfortunately, she's got her hands full with the hurricane. So we're wishing her and her family the best as they're managing life in Florida. So hopefully they're doing okay. But Neil, again, thanks for stepping in, man. Appreciate it. Appreciate your lending your expertise for us. So today, what we want to talk about is really mythbusters. We've all heard so many different things dealing with patients, all these crazy myths that we hear, and we want to kind of debunk some of the really basic ones and talk about what's true, what's not true, and then how do we answer these questions, to somebody who really doesn't know anything about refractive surgery. Our patients, they don't know, what's what. So how do we explain that and really lead them into the right way, especially in the world of Google, where you can find anything you want. So let's get to it. Myth number one. So everybody here, we've all had experience with the light adjustable lens, of course, right? So patients who have been poor monovision contact lens wearers are bad LAL candidates. I hear that all the time. So Ken, why don't you lead it off? I mean, is that something you hear? How do you handle that? Is that a myth? Is that true? What do you think?
I think it's a myth. I personally have the LALs. I can't do monovision to save my life. It's not happening. And what I tell patients is, it's not monovision because of the depth of focus of these lenses and the range of focus. We're really only offsetting the eyes a little bit. A couple clicks, minus 0.5 or minus 0.75. And it's very adaptable. And I try to move away from the monovision. I say I don't compare these to contact lenses because they're in the eyes, and the range of focus is such that we don't have to think that way. If you think of true monovision, we're using monofocal contact lenses, one point of focus. So if we put one out there and one up here, we do that. That is very different than what we're doing in a light adjustable lens. We have a range of focus and they overlap. And so, I refer to the blended vision a lot, where we might offset something slightly, but we're not. I do think that's a myth. That especially with the LAL plus, it doesn't take much to offset to get that near range in there comfortably.
So Ken, when you're doing, monovision or blended vision, how much do you end up having to sacrifice in the non-dominant eye typically?
Really, not a lot. Most of my patients, will maybe they can get 20/20 minus in that non-dominant eye or 20/25. I think that's realistic. And they're J1 plus at near. So I don't go for a big offset at all. I actually start out very modest, and that usually gets it.
Yeah. Josh, anything to add there? I mean, what do you
I
think?
think Dr. King was totally right. I really like his term of the blended vision. I completely agree that it is a myth. In my experience, pretty much everyone, if they, if the cornea is pretty darn good, there's no big issues, has great outcome with LAL. And I do just like Dr. King mentioned, when I'm doing the adjustments, I do not all, but most of the adjustments with the Williamson Eye Center down here in Baton Rouge. And I'll start off just offset a little bit, and those patients will tend to come and end up with 2020, 2025 distance, more often than not 2020. And then just like you mentioned, that J1, maybe even J1 plus up close. So in my world, monovision kind of is a non-factor in regards to a patient being a non-candidate for LAL. Everyone's really a candidate for LAL. Even disturbed corneas, they know the fact that as long as they understand that this is the best technology that we have out there to give them the best vision possible after cataract surgery, even those folks
Right.
are a great option for LAL. So definitely a myth.
What about you, Neil, from the surgeon perspective? I mean, let's say you've got somebody coming in with dry AMD, they got some macular changes, or, I mean, even patients who may be getting active injections, but things are pretty quiet at the macula. Somebody who's monovision, that's something you could consider in those patients?
Oh, absolutely. I mean, yeah, I think, I agree with the other guys that I think it's definitely a myth. I mean, to the point now where I don't really even bring up monovision history very often in these patients because, I think it is very fundamentally different than monovision. The conversation I have with my patients, I agree. I use the blended vision thing a lot, but usually what I tell, and especially if patients have brought up monovision or if their referring optometrist said, hey, they've done monovision, didn't tolerate it, or whatever the case may be, and at least have some of that history. I'll say, hey, look, with traditional monovision, in a best case scenario, each eye is doing 50% of the work, right? And most of the time, it's not that, right? It's like one eye is doing 25% of the work, the other eye is doing like 40, 50% of the work. And there's going to be a gap in your vision if you're presbyopic, right? That's just what we know about our presbyopic monovision contact lens patients. This is like both eyes are doing 80% of the work. And so it's like, you're not really missing much and you're not losing stereo. You're not going to have issues where your eyes aren't working together because if you close your quote unquote distance eye, your distance vision will likely be better than it is today and you won't notice a difference. And that I think holds pretty true, certainly with the LAL plus, but I think even with the LAL as well.
Yeah.
I think that
Yeah.
I hate to interrupt, but what Dr. Neal just said was super powerful. I've never heard it worded that way in regards to monovision being, one eye getting 20%, one eye getting 40, 50%. That's a great pearl. I'm going to take from that here.
I was going to say, I'm going to steal that.
Yeah, me too.
You got it.
That was great.
I think that's a great way of putting it. I always use my hands, right? I played baseball in high school and a little bit in college. So I always talk about, man, if you gave me, I hate it when patients come in after we've done a bit of a blend and they do this thing, the refractive salute, where they're looking. It's like asking me to throw a baseball with my left hand. It's going to look terrible. But man, if you give me 100 pounds to carry up a staircase, it's nice to have both hands. They have their gives and their takes and the balance. You're trying to treat the whole system. And it's really important, I think, for patients to understand that it's not just an individual eye treatment that we're doing. It's the whole system, the brain's included. And so that blend is very tolerable. Ken, let me ask you this. I mean,
Sorry, hey, Nick, I just want to add one more thing before we jump in. Just to piggyback on that point. The other thing that I talk about, which I think is really helpful in these situations, is reassuring the patient that the beauty of this technology is you can go backwards, right?
Yes.
So, I think patients always worry, oh my God, what if my brain doesn't handle this? Especially the really analytical patients who read about the technology, and look into the data. And we all have patients like that now that data is so readily available. And I'm just like, hey, look, after your first adjustment, if you feel like your eyes aren't working together, we'll back it off. And the only downside is you might lose a little bit of near, but you're still going to have, 80% or 90% of the range that we're looking for. And most patients are like, oh, I like that idea. I'm not committing to anything today. So I think that works out really well in these patients.
Yeah. That sense of control, I think, is so powerful. And people really love that. Almost too much. It's like if you give a mouse a cookie, they want a glass of milk and they're going to keep going around and around in a circle. So you do have to still drive as the doc in the exam. You still got to drive, but giving them options is great. Ken, let me ask you this. So there's a way to broaden the depth of focus with the LAL, and it's kind of a unique set of circumstances that you have to hit to broaden that depth of focus. Can you talk about that maybe a little bit?
Sure. I mean, to broaden the depth of focus, we want to what we call set off the negative spherical aberration in the non-dominant eye. So you need to move it. When you do your first adjustment, you can set off that negative SA by taking that eye at least to minus 0.5. And that will broaden the range of focus in the non-dominant eye. And you don't do that in the dominant eye. And that that gives you an extra boost to the near without moving it back away from the distance very much. And it actually works very, very well. And so you need to go at least in, a half diopter to minus 0.5 or minus a half to get that to happen. And there are times, I'm going to be real honest here, that I don't even have to do that. I may not set off that negative spherical aberration, and I'm still getting, with the LAL plus, I'm still getting the near I want. Because then if you have a patient who's a little iffy, then you're able to about their their monovision or their distance or their eyes working together, they can we can bring them in a little bit, and we don't have to necessarily set that off, and they still gain some reading with just a little bit of a blend. Is that kind of what you were looking for there, Nick?
Yeah. There's it's the first treatment, I think, is the key there too. I don't know if you mentioned that.
First treatment.
Yep. First treatment moving in towards the myopic direction. Both meridians in your power cross have to either stay neutral or steepen. So they have to move. You can't be moving in a hyperopic direction. You have to move in a myopic direction. That first treatment, you will induce added negative spherical aberration, which works to broaden the depth of focus even more. It probably gets you, I mean, in reality, maybe a quarter to a half diopter of broadened depth of focus. And so you can combine that with, especially the LAL plus, which is already getting you probably an added quarter or a half. And you can take that, and for my LAL plus patients, we're not going much further than -1 in the non-dominant eye pretty routinely. I mean, we don't really have to.
No, you don't.
Yeah. I mean, rarely am I going any further than that. Because once you do that, then you are getting into a more true monovision, and that defeats the purpose. And patients maybe who are very tolerant to monovision contacts, we may push it further, but they're just used to that. You're losing depth perception a little bit if you go further, but they're still functional if you don't, and that's the goal. I tell my patients all the time, you should be able to see your phone very comfortably. You should be able to do casual reading pretty comfortably. Computers should be a piece of cake. It's the knitting or sewing or things, tying fishing lures. I got a lot of fishermen up in Wisconsin. I can't see my well, yeah, that's tiny stuff. Let's be realistic here. And that's where you might need to pull out those cheaters. But for your daily functional tasks, yeah, you really shouldn't need it.
I want to.
Yeah, Josh, go ahead.
Yeah. When we've been doing LAL for a little while now, years, and gosh, as soon as I don't remember who told us or when the change happened, but as soon as we started kind of shooting for that minus 0.5 target, on that first adjustment in that non-dominant eye, it really did improve a lot of our patients' reading. So you're not kidding about shooting for that, minus 0.5 in that non-dominant eye. It really did make a big difference in us. We've been doing that for a couple of years now, but as soon as that change kind of went into our protocol, what a difference.
Is there anybody you wouldn't want to do it on?
Ooh, yeah. Any kind of RK. We have a lot of RK patients down here. Louisiana and Florida was like RK. So we had so much.
Texas is not far behind.
Yeah, I would bet. Yeah. So, I just find that with all the different aberrations that those folks do have from that cornea, inducing any other aberrations probably not the best idea. So in my experience, I haven't had a lot of luck with that. With RK patients, man, I'm just shooting to try to give you the best possible, overall vision. And they know they're going to have those fluctuations even with this great technology. So really the RK eyes.
Yeah. Same with us. I mean, RK kind of is great with this. I don't shy away from RK like I would any other procedure because their corneas are almost like multifocal contacts to begin with. They've got depth of focus. Their vision qualitatively is probably trash, but they do have range of vision and they're used to it because RK was done 30 years ago. And so we can use that to our favor. So we can target plano for these eyes, and they're going to fluctuate, but they're usually pretty damn happy with their outcome.
Can I ask y'all a question? Because this has been on my mind, and I don't know, when you have an RK patient and you see a lot of aberration on the pentacam or whatever, would you ever, do you think about LAL versus LAL plus? Is that something that enters y'all's wheelhouse because I don't. I'm kind of wrestling with that a little bit. I'm like, because I all of a sudden I have like 3 RK people walking in the door. So I'm just curious about y'all's thoughts on that. I'm looking for some input there.
Yeah, I don't. I mean, just to jump in. So for me, to Josh's point, in an aberrated cornea, like try not to add any more aberrations to the mix, and I kind of had the same philosophy before I had LAL in my practice about multifocal EDO FIOLs and like post-refractive surgery patients or certainly post-RK patients. I was like, unless it was a really, really slam dunk looking cornea, I always tell people like, there's a lot of really smart surgeons out there who can like quantify aberrations and match them up. Like, I don't think I'm like that smart. And so for me, it's, if I don't know, I'm going to be able to make this optical situation better. Like, it's better just to kind of be conservative. And so the approach I've taken is if this was a patient that I would consider an EDO FIOL in, I'll put a plus in. If it's not, then I'll stick with the and so far, we've been doing this about a year now. And I feel like that sort of philosophy has worked out pretty well. We haven't had too many, wild surprises doing that.
Thanks.
That's what we
appreciate
do.
That.
If you do an EDOF lens and an eye, do a plus. If not, do an LAL. The LAL, I mean, when you look at the data points, the LAL versus the LAL plus, technically you're probably giving up a letter or two. It's very, very little. But
Right.
I mean, in refractive surgery, you're trying to control all the variables that you possibly can. That is a controllable. So don't give anything up if you can avoid it. That's my philosophy, at least, just like what you said, Neil. I think that's totally fair.
Thanks.
One thing I'd like to add too is with those RK patients, and again, it sounds like Dr. King gets a lot as well. Most of our RK patients do understand they're never going to be perfect anymore. They've got a bunch of damage to that cornea. And if you tell them, hey, in my opinion, this light adjustable lens is going to give us the best outcome and the best chance of giving you your best overall vision, because you're going to heal up probably a little different than everyone else after cataract surgery. And we can kind of take that into account because guess what? We can adjust your prescription after the surgery. It usually makes sense to them. And there's something very powerful letting them know, hey, this is the best we got for you.
Yeah.
Perfect.
And just to add to that point, I think the other thing too is, obviously like discretion is the better part of valor, right? You want to be, to your point, be conservative. But at the same time, I think my philosophy on cataract surgery in these RK patients has definitely changed because, I used to think, hey, I'm going to take their cataract out, I'm going to put a monofocal lens in, and then they're going to go back to wearing glasses or contacts or whatever they did before. This is like medical cataract surgery, get the cataract out because it's a problem. I think as my confidence in our LAL program grows, you start to realize that these patients have appetites for glass independence just like any other patient, maybe even more so because they had a long time of really good vision, and I think if you're not offering these patients a technology that you think has a good chance of giving them this outcome, I think you're kind of doing this patient group a little bit of a disservice. And so I think that's where, as you kind of get your feet wet with this technology, and once you start seeing, hey, this is really good, as long as you temper expectations, to your point, I think it's a go in most of these cases.
Awesome, good points, guys. Let's get to our next one. So this is there we go. So this is something that I hear as an optometrist quite a bit. I think the old MD versus OD just kind of butting heads, almost territorial, where FLAC, so femtosecond laser assisted cataract surgery, doesn't provide any benefit over manual cataract surgery. I think in the optometry world, I hear that quite a bit. And in the refractive world, now that I've always been on the other side, I've worked in refractive surgery my entire career, I see it a different way. I'm curious what you guys think. Anybody want to take this one?
I'll go first.
Josh, go for it.
I kind of come from an interesting standpoint in the fact that before I was at Williamson, I was at a much older surgery center, probably about a decade ago. And they did very little FLACs. They did very little, fancy cataract surgery, very few multifocals and all that. And so I got to see all the post-ops there, everything done by hand, all that good stuff. And then Williamson, where I'm at now and have been for a while, we've got all the fancy stuff. And I mean, what I see, just clinically, I don't know the studies or anything like that. Just what I see in my chair, I find that the patients tend to be happier faster. The target seems to be closer to the goal, and they seem to heal up faster. That's just clinically what I see. So, and when I hear it explained to patients, like, yeah, we can do everything by hand, it's a great surgery, or we can use lasers to really assist us and do a lot of this work. We're in the eye a little bit shorter time, all that good stuff. Everything seems to be more accurate. It makes sense to the patients. And now that I'm on this side, I almost feel bad for the patients that weren't offered the flax.
If I could add to that, I have had a similar experience in that when our practice first started, we were using a surgery center at a hospital until our surgery center was built, and we didn't have flax. And when we opened our surgery center, we installed a system, and the speed with which patients were recovering, the decrease in inflammation, the accuracy of our toric placements, it just increased. It was actually a wow. Like when we got our surgery center opened and we started doing that, I literally walked up to Dr. Strange and I said, "This is pretty amazing. These people look different on day one after surgery
Mm-hmm.
than what we were doing before." And our, I can't, just the toric placement and stuff like that. It's amazing. So I saw the difference in the outcome. And I just had a patient recently going, "Hey, I did some research and they said that this laser assisted isn't any better than manual." And we sat and talked about it for a while. And I said, I tend to disagree. And to Josh's point, I always tell patients the human eye doesn't like to be messed with. Get in, do what you have to do, and get out. And if flax allows us to get out faster, we have better recovery. So I've had a very similar experience. I can't imagine, we offer it. Everybody gets offered that.
Neil, what about
So
you? What do you think?
Yeah. Yeah. So I think, my perspective is I think this is absolutely a myth. I think the issue we run into where this myth kind of comes from is I think in general we've gotten really good at cataract surgery as kind of as a group, right? Not only as our surgical training gets better, volumes, we all get, do more surgery, but also just FAAO technology, right? We have machines are great, chambers are stable. We have all these fancy other tools when we have dense lenses. So we have so now when you're starting to see, okay, what's the benefit of an added technology? You're working in really slim margins, right? So we look at data, for example, right? And it's hard to prove statistical significance for something that's going to be a very small change. But that being said, a small statistical change doesn't mean it's not a real clinical benefit. And you guys are seeing that in the clinic, right? When you see these patients in post-op, they look cleaner. I think when I talk to my patients, I always say, hey, look, we offer laser assisted cataract surgery. It's laser assisted, so 80% of the surgery is still done by me manually, but this helps me with a couple of really important parts. If it was free, I do it for everybody. It's not free, and so there's a cost component of that, and that always goes into the patient's cost benefit analysis. And then I go into, okay, in their particular case, are there things in their particular case where I think that cost benefit weighs more heavily in their favor? So certainly premium IOLs where you want that nicely perfect, round centered rexus, or toric alignment is great, especially if you're working in between toric powers, right? It's nice to be able to do a little LRI to really knock down that astigmatism and line up the toric IOL to those arcuates. That's super helpful in the OR. And then think about dense lenses and patients with Fuchs and all the other sort of peripheral cases where there's getting in and out faster is going to be better for the patient long term. And so I think when you look at those cases, it's not every case that you're going to talk about, but that doesn't mean that every case can't benefit from it.
Great point. I mean, that's I think great point. I tell patients that all the time too. I mean, if it were free, we'd do it all the time. Now, when you're trying to, there's really no such thing as a non-refractive cataract surgery nowadays. Everybody comes in with some expectation. And there's advantages. There's several different advantages with femtosecond. Number one, it's going to make the healing process, like you guys all said, it's going to make it quicker. These patients are happier faster, and our patients are extremely impatient too. So getting them happier faster, that makes my job a lot easier. Awesome. But then, cylinder. I mean, astigmatism. We can manage astigmatism at a lower level. Would you ever treat 0.75 diopters in a contact lens? Josh, you're the contact lens guy. I mean, would you put that in a contact lens?
Pretty rare occasionally. Very, 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 very rarely.
Well, you could. I mean, you could also do that with cataract surgery nowadays too, or a diopter. Toric lenses sometimes, a diopter is kind of where they start. So we can treat that and much more accurately. So we use the LensR system, the Ally system in our clinic, and we love it. I think a big part of the Ally system that's so great is it does have iris capture. So you can actually look at the crypts on the iris. So when patients lay down and they cycle or rotate, it can fixate on that landmark and be much more accurate, which is super, super cool. Not only that, but the toric markers. Neil, you mentioned the toric markers. We can now manipulate our toric lenses to line up exactly where they're supposed to be. It also kind of holds us accountable for our co-managing doctors. They can now see where that lens is supposed to be, and they can see if it's not lined up. And lenses can rotate. That is something that happens maybe 3% of the time. So that's just an advantage, again, to keep us all on the same team. Do any of you guys use femtosecond with the LAL? Speaking of toric and astigmatism management.
Yes, with all LALs we do.
Okay.
It's great to help debulk. It allows us, because the LAL has a certain amount of cylinder it can do and whatnot. So it helps us to debulk the cylinder down a little bit, which leaves us more room to adjust and manage.
What's your threshold? Like, where do you consider doing an AK?
We actually will use it, anywhere, but our threshold with the LAL is, we don't go over 275 too often. So a lot of folks do more than that. I'm a little conservative on that. As far as SIL goes.
Josh, Neil, do you guys have a threshold where you will or won't do an AK?
Yeah, around 3. If I'm 250 to 3, I'll throw in an AK, either femto. I don't do a ton of femto with my LALs, and that's mainly a cost issue because we don't own our femto, and so the cost starts to add up pretty quickly to the patient. But a manual LRI in those cases, and actually it works pretty well actually.
Okay. Josh, anything there?
That's above my pay grade. That's a Blake Williamson question, to be completely honest with you. But
totally fair.
I do want to just really emphasize that I get asked all the time by my patients, whether it's a friend or a family or just they've learned about all their options for cataract surgery, and they just ask me, what do I think? And one of the most popular questions they like to ask me is, what would I do? What would I recommend for my mother, my father? And without question, I would recommend femto. So I think that, letting patients know that, because it's true. I think there's something very powerful for that.
Yeah, I think in the optometry world, especially, and maybe it's a generational thing, but sometimes it's thought of as a money grab. These greedy surgeons just want the money. But I mean, if you ask any surgeon, and surgeons, Neil, I mean, you're a surgeon. I mean, surgeons tend to be pretty confident in their skills, as you should be. You're very talented people. So asking a surgeon, would you take a very important part of this procedure and use a laser to do it? Almost all surgeons that I would ask probably would have the laser do their own surgery, right? I mean, would you want the laser done for your surgery, Neil? I
agree. I agree. It's like, to your point, I mean, there's a lot of really, really great surgeons that I would happily trust to do my cataract surgery. But if I have the access to the tool that takes that part out of the equation, I mean, certainly there's no downside.
Totally. Yeah. I want to take one moment real quick to remind everybody who's joining us, go ahead and submit questions. There should be a box to go ahead and submit questions to our panel. We'll kind of read those off as they come. So make sure you keep this interactive. It's a lot of fun if we can keep it moving. Let's get to our next myth. So let me see if I can advance the slide here. Okay. Myth number 3, LASIK is the best option for our low to moderate myopes. So let's say like -3 to -6. LASIK is the best option. Josh, why don't you start this one off? Do you have any thoughts on this myth, or is it true?
I've got experience actually. Yeah. So I was a -550 and a -6. And LASIK's great. We do a lot of LASIK. It's wonderful. I cannot think of the last person that I've seen that had LASIK that wasn't ecstatic with their outcome. But I mean, personally, I would say myth for me. When I looked at everything, I've got some baseline dry eyes, a relatively moderate to high myope. I chose ICL. So when it came time to get surgery done on myself, I had the Evo ICL done. And for me, I felt like that was the best option for me. So I would say myth.
I remember talking to you about this back a year or two ago, because you were considering, you were like on the early stages of looking into it, and I'm like, man, you're -6. Like, yeah, because we do LASIK too. LASIK's great. This is not meant to bash LASIK. I love LASIK, but the Venn diagram in my head of where ICL and LASIK intersect, where it used to be very far apart, where ICL I would usually consider for like our -8, 9, 10, or people with thin corneas. There's a lot more overlap, and you're right in the middle of that overlap. You could go either way, assuming your corneas are good and healthy.
Yeah. I mean, and not that in my experience, our LASIK patients do suffer from, bad dry eyes or anything like that. I know older generations of LASIK lasers, yeah, obviously. But man, and I also looked at the healing process. So this is crazy. I did, hopefully it's all, eye doctors that are watching this and administrators, but 2 hours after Dr. Blake finished my procedure, I didn't even get general. I just, took a numbing drop and had it all done. 2 hours later, I drove myself home and just took a nap. So after I got my 2-hour pressure check done, I mean, that's pretty ridiculous. So for me, the busy life of a single dad of a 6-year-old, I didn't want, a day or two down. I just didn't want to do that. So ICL was perfect for me.
What about you, Neil? What do you think as a LASIK surgeon, ICL surgeon?
Yeah, I mean, so I think myth as well, because I think statements like, something is the best option, I think are kind of statements of the past. I mean, I think especially, as physicians, providers, doctors, eye care specialists in general, we like black and white. We write like, hey, this is the best, and then I'm going to do it, right? I think we have so many great options for things now that there's a lot of art to what we do now. And I think as much fun as it is to have a million different surgeries like at my disposal, my conversations with patients are getting longer and longer because the laundry list of options that I have to talk to them about keeps getting longer and longer. And really, especially in this low, moderate, myo kind of category, I was like you, Nick, where when I first started doing ICLs, I was like, okay, if you're not a candidate for laser refractive surgery, I offer you an ICL. And I did a bunch of it, and I was like, oh man, this is actually really great. The patients are super happy and they see really well. And, Evo came out, and now all the pressure stuff went away and the angle of closure stuff went away. And so I started pushing my threshold, I started pushing those Venn diagrams closer and closer together. And so, I've done a fair amount of low, -3, -4, -5 ICLs, and I've obviously, LASIK and SMILE and the other things in that group as well. And really those patients I think are my longest conversations, because I do offer them both. And I think one of the big things here is I think different procedures like speak differently to different patients, right? Based on their personality, based on their history, whatever the case may be. I think if you give them a nice understanding of the difference between the different procedures and the pluses and minuses of both, I think this is one of those situations where I tell patients, like, honestly, I think you could go either way. And that, sometimes we say that because it's like, oh, you want to hedge your bet. I really do feel this way. Like, if you're a -5, like Josh, and obviously if there's no other predisposing thing that makes you a candidate for one or the other, I think you can make the decision for laser, or you can make the decision for ICL, and be really happy with both. And I think that's a really big paradigm shift now that we have ICL technology that works and has very few side effects and all the other things that we know about and love about ICLs.
And I'd like to add to that something that tips the scale for some of our patients, because we offer both and we use the Evo. We actually have put a lot of Evos in optometrists in our area. They're choosing it. But when you talk to patients who are kind of nervous, which everybody is, the fact that ICL can be reversible if for any reason they're not loving it, which we've never had that happen. But that's a level of comfort for some folks that I've seen them kind of go, oh, well, I like that idea. When we talk about, especially these 4 and 5 diopter folks that really, they can't make a wrong choice, based on their scans and that kind of stuff. So the reversibility about it and the less dry eye, in DFW here, ocular surface is a big deal here. And it does when we talk about that, it makes a difference for the patient's choice too. So I do think it's a myth. We're doing it more in lower folks, and they're very happy with it.
So on your reversibility point, because I think that is really huge, would you say that, I mean, if you live long enough, these are completely reversible, and inevitably they will have to be reversible. So
Correct.
do you think what we know about I mean, we're starting to understand higher order aberrations better than we ever have. We've never been able to quantify them like we can now. Is our understanding of higher order aberrations maybe pushing one way or the other? Because LASIK, we know that we're going to make a cornea, at least a myopic treatment, kind of flat in the middle, and that can impact a lot of our premium lenses. Does that affect it or affect your decision?
I'll actually explain to patients when we talk about this that, you know, this is a lifelong decision, and the EVO ICL, we're not actually changing your eye, we're just adding something to it, and it will give you potentially a lot more options down the road later on in life when we have to take these out when it's time for cataract surgery or something like that. And we're going to have more choices of what to put back in there than with LASIK based on your corneal curvatures and your measurements.
Yeah, great point. I mean, with me, especially if it's somebody who's like approaching, and this again off label, the label says, I can't remember the exact age for ICL, it's 40, 45, I think. But
45, yeah.
yeah, 45. So if we're in our low 50s and we're kind of approaching that magic age of maybe cataracts are going to be coming up soon, I would much rather go for ICL. Now, if you're 20 and we don't know what cataract surgery looks like in 40 years, we may not be doing cataract surgery in 40 years, who knows? But if you're in your 50s, cataract surgery inevitably, I mean, we're going to be doing that. And that, I think, for me at least, comes into the decision quite a bit. If you're on the fence of doing LASIK or ICL, let's preserve that cornea. Let's leave it. Let's try not to induce permanent higher order aberrations, so we can have the full gamut and the full array of premium IOLs on the table. Now with the LAL, of course, it's not as big of a deal because we can adjust like we talked about earlier. But for other lenses, DDOF lenses, multifocal lenses, to have a pristine cornea really matters. And I think to have that is just of huge value. Staying on the ICL.
Just to add,
yeah.
sorry, 1 second. I just want to add to that because the other thing, beyond cataract surgery, I've also dangled the carrot of patients in that kind of same age group that you're talking about, Nick, maybe mid 40s, pre-presbyopes, is that there's nothing that tells us that in the next few years we're not going to have a presbyopia correcting ICL available, right? And so I've told patients who are close to that age, like, hey, look, there's already, this type of thing is available elsewhere. In 5 or 10 years, if we have that technology here, I can't promise you that if you've had laser to your cornea, you're going to be a candidate for that technology. But I'm fairly confident that if you've had an ICL, I could probably swap that ICL out for a presbyopia correcting IOL in the future if it's available. And I've had patients actually take me up on that exact point, because I do think that that's a more sort of intermediate, near term advantage to them.
That's a great point.
One thing I do want to add before you click over, I'm not sure what the next slide is, I forgot. But, one of the things that was really powerful to me when I was also looking at, my options was just the fact that, when you have an ICL done, that correction is closer to that nodal point. And I did think that was one of the things that spoke to me. That would probably speak to a lot of it sounds like Dr. King's doing a lot of these on his optometrists that understand that as well. And to a lot of the engineers and the folks out there that really kind of get into that. So that was one of the things that I felt like was a better option for me.
Yeah, you nailed it. The nodal point, that's the magic word. I mean, if you actually look at the FDA study and all the literature, it like 52%, I think, of patients actually improved best corrected vision. So they come in their 2020, they leave their 2015. How the heck does that happen? It's all retinal image size because you're correcting things right at that anterior crystal lens plane. That's why, for our moderate to high myopes, you'd rather wear contact lenses instead of a pair of glasses. They're not minified as much. So by that theory, why not correct things even closer to that magic nodal point, putting something at that plane? So Josh, let me ask you this, because you've had the surgery. Is there any problems with glare halos? That's another kind of myth with ICL, that the halos and the glares are going to be problematic.
I am actually, I'll be 19 weeks out tomorrow. So I'm still pretty new, which is kind of cool for people to hear.
Yeah.
Yeah, the first couple of weeks, yeah, there was some glare in halos. Nothing that was bad. I'd wake up in the middle of the night and I'd look up, and the little light on my TV, I'd have some halos around it. And it's like, oh no, there's a halo. But you know what? I can still see. I don't have to be fumbling for my glasses. And then what happened is I would have to kind of move my head around eventually to try to find the rings. So, I have a light in all of our exam rooms, like right up here. I'd have to move my head just the right way to find it. And so now I have to work to find the halos. Other than that, it's really not bad at all. Like I said, I really have to kind of strain to find it. And it also is quite powerful too, because I do pretty much all of our ICL follow-ups. And you'll get that engineer 4 weeks, 6 weeks, 8 weeks, 12 weeks that comes in and they say, yeah, everything's great. I'm happy, but man, I just can't deal with this glare. When my head is like this, I have this ring. And now I can tell them, yeah, I have that too. And it's getting better every day. It gets better, but I just don't do that with my head, and I see fine. And you just don't do that, and you won't have an issue, and it's going to continue to get better and better and better. So the short answer to your question is I did right at the very beginning. It wasn't debilitating. I still drove at night. But now I really have to work to find any of those rings. So barely there.
It hurts when I do this with my neck. Well, don't do that.
Yeah, exactly.
All right. So staying on ICL, I think this myth I hear a lot, especially, I guess maybe not so much anymore, but I definitely still do hear this from patients who come in and they've done their homework. ICL leads to the early development of cataracts. So Josh, since you're the expert on the ICL, how do you handle this one?
I had a patient today come in. She was kind of a self-referral, and she was just wanting to know all about the different refractive surgeries we did. And I said, well, I did ICL just like a couple months ago. And she says, yeah, but man, I read and I just don't want cataracts happening any earlier. So I literally brought up the picture and I showed her why this slide is a myth. So definitely now I would have to say the Evo ICL leads to early development of cataracts. You could say maybe earlier generations did, but my Evo ICL, upon my research, I feel like it does not. I'm not worried about leading to early development of cataracts. And that's because when you actually look at the lens, there's all these little holes that allow all that fluid, aqueous, to kind of flow basically in front of the lens and behind the lens. No need for sorry, my puppy just hit my leg. No need for a PI or anything like that. So I would stand strong upon my research and my experience that that's a myth.
Neil, what do you think?
Yeah, I agree, and the approval studies support that, right? So I mean, however many patients, 2,000, whatever was in the FDA approval studies, no incidence of cataract. I mean, that's a pretty strong thing in your favor. And again, it's all modern ICL technology. I mean, I think the same conversation, that we have now for surgeons who are first getting into, Evo ICL, there's still a lot of, I think, to use a surgical term, scar tissue from older ICL technology that still, weighs heavy, not only in, patients' minds when they do research, but also, surgeons who maybe used older ICL technology and abandoned it for the various issues that came across. Like, this is not the same. I mean, I wasn't around I was around, but not practicing, not a surgeon yet. And when, the heyday of previous ICL technology, but I just, obviously we hear stories why people start giving up that surgery. This technology is just fundamentally different, right? The material is different. The holes are different. The physiology is different. And so you have to, treat it with a different lens. No pun intended, I guess.
Yeah, I think, the previous version of Visian without the hole and where we had to do the pre-op PI, very different. And, we did a number of those, and yeah, it wasn't perfect. I saw a very healthy, happy 26-year-old, I think of one patient in particular that she happy 26-year-old 2015 vision came in with pressures of like 70. And that's something you don't really forget because she was in pain. She was in tears. She was puking. It was not a fun day. So pupillary block was definitely a real thing, or angle closure was a real thing. Not only that, but doing a PI, that itself is not a benign procedure, especially for somebody who's young and healthy. You have to use pilocarpine
Okay.
to get the iris to be very taut, and that can be painful. You're changing the entire aqueous dynamics of the human eye, and that alone can ignite a cataract. And so now, just not having to do that, we don't really need to worry about that. But yeah, the studies. I mean, it's not like the FDA did like 5 eyes. They did thousands of eyes, and there has been published literature on tens of thousands of eyes. And the incidence of cataracts was at like 1. Very, 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 very few. Almost shockingly non-believable how
There's always
low.
one.
Yeah, it just doesn't happen.
Always.
It's crazy. So because you're preserving, there's always going to be aqueous flow between the lens itself, the crystalline lens, and the ICL. And the other thing too, especially when docs are starting to get used or just starting to get under going with ICL, I think there's still this concern about vault. You don't want the vault to be too low. You don't want the vault to be too high. And it is something you still have to measure properly. But I don't think vault is really as important as it used to be. It used to be incredibly important because if you have the lens touch the ICL, then that's a cataract. If you have it too high, then your pupillary block or angle closure. Now, if you're too low of a vault with the EVO, you still are going to get aqueous flow. They've done dynamic studies that there still is fluid, and you're still having that preservation of the anterior crystalline lens with normal aqueous. You're preserving that physiology so the cataract won't develop. The thing you got to worry about is overvaulting, because if you overvault, you can still have angle closure. That can still happen. So it's not like we can ignore the vault. We can't. We have to pay attention to it, but it's not as problematic as it used to be, which is great.
It's almost like we do have extra safeguards now that we just didn't have before. So I think that myth just needs to go.
Yeah. We just don't have to be as crazy about it, and it has completely opened the doors. We're not worried about it anymore. I mean, when I see patients back for their day 1 post-op, if their pressure's a little high, that's not uncommon, but we deal with it and it's okay. It's not like with the Visium where if it was high, I'm worried that it's going to stay high and we're going to have a phone call at 2 a.m. I'm going to have to come in and do something about it. So I got one more myth. Let's get to it. So let me see here. All right. One more time, back onto the light adjustable lens. So I was a believer in this myth in the early days, that the LAL is going to take too long and it's going to be a huge turnoff for people choosing a premium IOL. So, hey, Cam, why don't you lead this one off? How do you handle this myth or concern? Or is it a myth at all, or is it truth?
I would basically call it a myth, but when I counsel patients on this, I do let them know that this post-op period is going to be a little longer than if they had a different lens in their eye, because we wait a few weeks before we start adjusting. So I'm very real about it up front. That if you have to travel, we're going to do that. But we are the advantage is that we're going to be able to customize this more than we could with any other lens, and this is the lens that could give you the best outcome for your eyes. So yes, it's going to take a little longer than some other lenses, but what's too long? I don't know. If we really want to get to that goal, because this is a lifetime decision, it doesn't turn out to be a turnoff for too many of my patients. I think I've had 2 that said, I just don't know if I'm so busy. And I'm like, okay, but we talked about it. So I would call that a myth.
Neil, anything to add there?
Yeah, I mean, I think I agree with everything, Ken said so far. I think for me, I put my LAL patients into kind of 2 buckets. There's like the patients who are like, if you want, glass independence premium cataract surgery with a premium IOL, given your other medical factors with your eye, it's either the LAL or it's a monofocal IOL. For those patients, it's a pretty easy sort of thing. For them, the juices definitely works to squeeze because they're like, hey, this is my only real option, right? On this slide, talking about patients who are considering other premium IOLs. I do think there is some nuance in picking a patient, at least when I'm talking to patients in counseling, about who I think is going to value the technology and therefore is going to be willing to take on both the time commitment and the financial commitment ultimately for the light adjustable lens, right? And so the analogy I use a lot is like the custom tailored suit, right? So I talk to these patients like, hey, look, this is a custom tailored suit. Now you're going to go back to the tailor to get the sleeve adjusted, to get the, the whatever, and you're going to go 3 or 4 times. You never think about that. You just think about how good you look when you put the suit on, on your big day. And that's exactly how this lens is, right? You don't think about the journey once you get to the end point. And so I think if you frame it in that way to the right patient who you think is going to respond to that sort of analogy, I think there's a lot of patients like, yeah, I absolutely will come in for those 3, 4, 5 extra visits because I think it's worthwhile. Now, there are, I think, some patients to Ken's point where, either they say they're too busy or, I think there is some, when you get long in the tooth about some of these counseling conversations, you're like, oh, you have all these visits, you have the sunglasses. Sometimes patients are just like, this sounds like too much for me. I'm just going to kind of, go with the what I heard my neighbor got. I think some of the patients there is a little bit of that, but I don't think it's as many as I thought going into our LAL journey as well.
Josh, what about you?
It all goes down to verbiage. And I think Dr. King really put it well there, that, this is a lifelong decision. And if you really, let patients know that, hey, there's a lot of different ways you can verbalize things. But if you tell a patient, hey, we're going to be doing the cataract surgery, and then we're going to let you kind of relax for a little while and experience your vision, give it a test drive. Then we're going to bring you back, tell us, maybe what you want change, what you're noticing. Then we'll make another change. You'll still be able to live your life. We're not asking you to live in a dark room for 6 months. Go about your life, see what you think, come on back, and we can make a few more adjustments and kind of go from there. So again, how you verbalize it is really important. And another thing too, those patients that think that they are too busy, and they may be too busy, they're also the ones that tend to feel like they need total control because they're going to tell you how busy they are and how important they are and all that. And what better procedure for someone that wants total control than literally someone that can have surgery, experience the outcome, and then say, no, I want this changed. Can you help me with this? And they can do it multiple times. So it's really about, how you kind of pitch that to the patient. But we do ask for a little more time to really give our patients with the LAL the best possible vision for the rest of their life. So I can't say whether this is a myth or truth, because it is too long for some patients.
Yeah,
but
it's not black and white.
Right way.
I think you're right. I mean, it's not fully myth busted for this one, I think. But I will say my experience, I thought when we started doing this 5 years ago that this is going to take way too long. Nobody's going to buy it. Nobody's going to want to do it, because who wants to come see my ugly face 6 times, in this whole process? Of course they're not. But I think you hit the nail on the head, Josh, with your patients who want that control. The people who are really important, they're so busy, they're going to tell you all about how busy they are. Those are the ones who want the control, and those are the ones who naturally are drawn to this sort of thing. So I don't think it's a turnoff at all for everybody. Some people it is, especially up in Wisconsin. We have plenty of our patients who are approaching the winter months where they go down and they visit, Florida, Texas, Arizona. They're down in the southern states. And that's a timeline that puts a definite end on when they need to be done. Usually it's right around Christmas time. So we're kind of getting close to that, because I'm honest with patients up front too, that this process takes probably 6 to 8 weeks. We have to let you heal. And then we do one adjustment per week in our clinic. And when we schedule the adjustments, they're tentative. I don't say that we're going to do an adjustment if things don't look quite right. I always use the golfing analogy, right? We're putting. If we putt, we're aiming towards a hole. You cannot putt again until that ball comes to a rest. And so if you come back for your next scheduled adjustment, it's still not right. Maybe your numbers don't make sense. Maybe your eyes are a little dry. Maybe something else is going on. We're not going to do a treatment. You only got 3 putts. Don't use one on something that's not stationary and we don't have a good read on yet. So everything is tentative. So just budget that time. Time is our best friend. I mean, if you want to take more time, take it. That's your time to test drive. And so I think for more people, more than at least half of our patients, the time is actually the appeal, because they don't have to commit to anything and they can really test drive it and take that time to really live with it. But for others, if they are restricted, sure, it is a turnoff, and that's okay. It's not for everybody, but for more people than I thought, I don't think this is, I don't think it's as much of a turnoff as I thought it would be. Well, awesome, guys. I think we busted some serious myths in cataract surgery today. So again, I just want to thank our sponsors, RxSight, Star Surgical, LensR. Huge help to you guys. Hopefully, everybody watching took something out of this. Make sure you follow us: LinkedIn, Facebook, YouTube, Instagram. Connect with us, ask questions. Peer-to-Peer Academy is supposed to be interactive. We want interaction. So give us ideas on what to talk about. If there's something that's really on your mind, or if you have any ideas for future webinars, let us know. Next one is going to be Tuesday, November 12th, and then Tuesday, December 17th. Make sure you visit Peer-to-Peer Academy, peer-to-peer.academy for the latest updates and everything, and get on the email list. And we'll keep this going. So thanks for everybody for joining. Appreciate it.
Thanks.
Thanks, guys. Yeah, that was fun.
Thanks, guys.
Bye now.
All right.